Today our group is looking at PTSD and how it affects the brain. I'm going to start by talking about some of the key brain regions and brain networks involved in PTSD. First, we're going to look at a few brain regions that are really important in PTSD. The amygdala is basically the brain threat detector. It's what triggers fear responses. Next, we have the hippocampus, and it's involved with memory, especially memories connected to PTSD. Next, we have the hippocampus. It's involved with memory, especially memories connected to trauma. Then we have the medulla prefrontal cortex, which helps regulate emotions and calm the fear response. In PTSD, the communication between these areas can become very dysregulated. PTSD isn't just about individual brain areas, it also affects how larger brain networks communicate. One example is the default mode network, which is involved in things like self-regulation and memory. In fact, research by Bio and colleagues in 2021 found changes in connectivity in networks like the DMN. Research has shown that this network can have reduced connectivity in PTSD. At the same time, emotional networks that detect that threat may become overactive, while regulatory networks that help control emotions may not work as effectively. Something important to remember is that not everyone who experiences trauma develop PTSD. After trauma, the brain stress response naturally activates and brain networks may change temporarily. For many people, those systems eventually return to normal. But in PTSD, that dysregulation continues and the fear system stays activated, which can lead to ongoing symptoms. The encouraging part is that the brain can actually change and adapt. This little miracle is called neuroplasticity. Research shows that approaches like neurofeedback can help people learn to regulate brain activity. For example, research by Berman and colleagues in 2025 show that neurofeedback may help improve brain regulation in people with PTSD. Over time, this can reduce PTSD symptoms and improve communication between brain networks. Understanding PTSD as a brain-based condition also changes how we approach. Creating a sense of safety is really important because it helps reduce threat activation in the brain. Supporting emotional regulation before processing trauma can help strengthen those regulatory circuits. And framing PTSD as a neurological condition can reduce shame and stigma. So overall, PTSD is not just a psychological issue, it involves real changes in the brain systems related to fear and emotion. The good news is that these brain networks can change and recover with treatment and support. Understanding PTSD this way can help reduce stigma and encourage trauma-informed care.
So the functional roles of the default mode network, or DMN, is a large-scale brain network that becomes active when the brain is in a resting state and not focused on external tasks. Several key brain regions make up this network: the medial prefrontal cortex, the posterior cingulate cortex, the precuneus, and the angular gyrus. So the medial prefrontal cortex is for self-referential thinking. The posterior cingulate cortex and precuneus are strongly involved in autobiographical memory and experiential recall. The DMN is also active during mind wandering as well as future simulation or rehearsed scenarios that we go over in our heads. These regions support cognition, helping us to understand other people's intentions and emotions. So the DMN does not operate alone. It interacts with other networks, including the salience network, the insula and anterior cingulate cortex. It helps the brain determine what is important and helps switch between internal thought process and attention to external stimuli or potential threats. So the resting state brain network before treatment in a study by Yolanda R. Schlumpf, the resting state functional connectivity in patients with complex PTSD or complex dissociative disorders before and after inpatient trauma treatment. So first of all, complex PTSD is not a official diagnosis. It relates to regular PTSD, but is more of an effect from prolonged traumatic events or a wider variety of traumatic events. And some of the symptoms specific to more of a complex PTSD involve distrust, reactivity, and can cause dissociation in some individuals. So in healthy individuals, the DMN shows coordinated resting state connectivity. Regions that communicate smoothly while the brain is at rest. So Schlumpf and her colleagues studied patients with PTSD, CPTSD or complex PTSD, and dissociative disorders as well. And what they found was reduced connectivity within these networks. For example, medial prefrontal cortex and posterior cingulate did not communicate as effectively and efficiently. So resting state abnormalities, particularly presenting in the theta and alpha frequency rhythms. Theta waves occur at about 4 to 8 hertz, and they're associated with memory processing and internal attention. Alpha waves, on the other hand, occur at around 8 to 12 hertz. They're associated with relaxed wakefulness and coordination between brain regions. When these rhythms are dysregulated, it suggests that the brain's large-scale networks are not communicating as efficiently. So EEG activity level measured before and after the 8-week phase-based inpatient trauma treatment program in Schlumpf's study. After the treatment, the EEG results showed increased and more normalized resting state connectivity, particularly in alpha and theta bands. These findings suggest that trauma therapy may help restore coordinated communication between those brain regions involved in memory, identity, emotional regulation, and improved connectivity areas like the medial prefrontal cortex and posterior cingulate cortex may reflect better integration of emotional experiences and autobiographical memory. So trauma recovery may involve more measurable neurological changes, not just things that we see in psychological improvements. So another important brain structure involved in trauma responses is the insula. So deep within the lateral sulcus, it helps integrate emotional awareness, body sensation, and sensory processing. The role of the insula in classical and dissociative PTSD presents a little bit differently. So in a double case study by Robin Blades and colleagues, they compared the insula activity with classic and dissociative type PTSD. Classic PTSD showed stronger connectivity in the anterior insula associated with emotional salience and threat detection. So that aligns with the fight or flight hyperarousal responses that we typically associate with PTSD. However, in the dissociative subtype, we see stronger involvement in the posterior insula, which is connected more to body sensation and internal regulation. So that's where we see more of the detachment, numbing, and shutdown that are typical of dissociative subtypes of PTSD. So the insula is a major hub for salience network. Between internal networks like the DMN and attention to external threats, disruptions in the system may contribute to different PTSD patterns.
So there's lots of different treatments for PTSD, but I'm going to be focusing on the psychopharmacological. Okay. So the current treatment for PTSD is SSRIs, or selective serotonin reuptake inhibitors, And these are good for regulating mood, appetite, and helping with sleep. And this leads to improved mood and less anxiety. Also, they also take a prazosin, and this is helps with their nightmares that they have when they are suffering from PTSD. But this medication does have some side effects. It causes hypertension or high blood pressure. It also can damage the heart, the brain, the blood vessels, and the kidneys. So it's kind of a scary medication to take. So even with those 2 medications that the patient might be taking, is that standard treatment doesn't really work. It doesn't get rid of all the symptoms. So now they're looking actually into the use of psychedelics. So some of the psychedelic medication, well, we want to increase the serotonin because that will help switches the brain, switches the serotonin switches in the brain. It changes how sensory information, our thoughts, and processed. Another medication is ibogaine, and that is hallucinogenic, and that can facilitate deep psychological processing and neuroplasticity. There's also, we want to increase dopamine, because dopamine is good for sending signals between the nerves. Ketamine alters the dopamine levels, so that helps. And then psilocybin heightens the amygdala reactivity, and that kind of has to deal with fight, flight, or freeze. So the brain is affected with these medications. The prefrontal cortex is a part of the brain that is affected, and that is for thinking and control center. And with these medications, it becomes a little less rigid and more flexible. The amygdala is our fear center, so that comes back to the fight, flight, or freeze, and it becomes less reactive. The hippocampus is for memory, and the brain starts linking things together more easily than usual. The only thing with these medications is that most of them are Schedule 1 drugs, and Schedule 1 drugs are not approved for medical use, and so we have to think about, some states have changed them, like California was one that had changed and made the use of this, because besides just PTSD, psychedelics can also be used for eating disorders, depression, so they really needed to do a lot more research and find out what they can use these medications for.
PTSD and evidence-based psychotherapy. So an overview of PTSD treatment. PTSD is a mental health condition that develops after exposure to traumatic events such as violence, accidents, combat, or abuse. The importance of treatment is PTSD can become chronic without treatment. Psychotherapy is considered the first-line treatment, often more effective than the medication alone. Evidence-based therapies are supported by evidence-intensive clinical research and treatment guidelines. Research consistently shows that trauma-based psychotherapies are the most effective treatments for PTSD. Many individuals who complete these treatments experience significant symptom reduction or even full remission in some cases. Importantly, research has shown that exposure-based therapies do not increase harmful effects when conducted properly by trained professionals. Many patients continue to experience benefits long after therapy ends, suggesting these treatments can produce lasting change. However, it is important to recognize that treatment outcomes can vary. The key goal of treatment, no matter what type of treatment it is to help the individual safely process traumatic memories, and reduce fear, avoidance, and distress. The common evidence-based psychotherapy interventions are prolonged exposure therapy, cognitive processing therapy, and trauma-focused cognitive behavioral therapy. With individual differences in therapy, that's kind of how you decide which one you're going to go with. The trauma history, the type of trauma, the severity of the symptoms, and the personal support systems in someone's life all play an important role in their recovery and which therapy they will choose. So, the major evidence-based psychotherapies for PTSD. noting that all effective treatments are trauma-focused. This means that they directly address traumatic memories rather than avoiding them. There has been treatment in the past that's kind of been used to push it down as kind of like a quick fix, but these therapies don't rely on that at all. So for prolonged exposure therapy, or PE, patients gradually confront traumatic memories in avoided situations. This reduces fear through repeated exposure and helps individuals learn traumatic memories are not dangerous in the present tense. Cognitive processing therapy, CPT, focuses on identifying and changing distorted trauma-related beliefs. This addresses guilt, shame, and negative self-perceptions. Uses cognitive restructuring and written trauma processing. We can see here the difference is there's journaling here. It's a lot more self-paced, and this one would be more paced by the physician or the counselor. The last one is trauma-focused cognitive behavioral therapy, TFCBD. Combines exposure, coping skills, and cognitive restructuring. This is the most popular one used. It's very light getting into it. It's not like, let's bring up the big event and go through it from there. It's kind of like addressing the problems you have current day and leading back to the roots, which in my opinion, it was my favorite one that I researched. It teaches emotional regulation and stress management skills, so it doesn't exactly try to diminish the PTSD event or try to diminish the harm that it's doing and the pain that it's doing. It's more just focusing on helping that person function and being able to like go through day-to-day life without, like having limitations from their traumatic event. And it's widely used across trauma platforms. The most effective treatments for PTSD, as I mentioned, are trauma-focused. Trauma-focused therapies directly address the root instead of burying it. Another type of therapy that it's used, but it's not used as much for PTSD compared to these other three, is EMDR, which is eye movement desensitization and reprocessing. It combines recalling traumatic events with guided eye movement, stop processing trauma. It's kind of a newer therapy, so I've learned through research that a lot of people don't tend to go with it just strictly because they haven't heard of it. They haven't seen as many positive outcomes from it, or there's just less research on it. And I understand like choosing a therapy that's been around for longer. I'm not sure if you can see this, I'm sorry. Effectiveness and clinical considerations. In research findings, based on the research study that I read and I mentioned in references, is trauma-focused psychotherapy show the strongest evidence for reducing PTSD symptoms. Many patients experience significant symptoms improvement or remission, as I mentioned in certain cases. Treatments are effective across diverse trauma types and populations. The average dropout for any kind of treatment, this like goes across the board and levels them, is about 18%. Exposure-based therapies do not increase of harmful effects when conducted properly. Long-term benefits often maintained after treatment ends with a lot of patients. Clinical considerations. Patient preference improves engagement. So if a patient is put with EMDR and they don't believe in it, they don't think that eye tracking is going to matter with their traumatic events, you're probably not going to want to put that patient with that type of therapy because they're going to be less engaged if they're not on board. The therapist training and adherence to treatment models are essential. As we mentioned here and kind of throughout the slides, it needs to be conducted properly since this is such a vulnerable population, and doing harm in this area of this person's life can do irreparable damage. Like PTSD is already doing so much damage to the individual that going to a specialist and maybe reliving that trauma and making it worse is just not worth it for a lot of people. This is why it's really important for therapists and counselors to follow the guidelines when using their specific type of therapy so they're not harming their client. Individual differences will influence how therapy works best, as I mentioned, and then here are our references. Thank you.